So let's make up a patient, right? So we'll make up a standard pacemaker patient. So let's say it's a patient who's got complete, not complete, let's not go complete, paroxysmal AV block, right? So they've got paroxysmal second stroke third degree AV block. They have the normal sinus node function from what we can see. And they are a 65-year-old female with normal cardiac function, reasonably normal cardiac function, okay? So that's a not atypical pacemaker patient, would we agree? It's okay? So 65-year-old female, normal sinus node, intermittent AV block with some syncope. So we decided to put a pacemaker in. Reasonable to put a pacemaker in, yeah? You choose a dual chamber? Yeah? She's dual chamber, okay. We don't know if she's got paroxysmal AF. She probably has. She's the right age and stuff, so she probably has got it, so we probably want to pick that up. Okay, so we'll start with, we'll just go into we'll just go in here. This is where we can set this device up for this lady. So remember, we don't know whether this lady's ever going to come back again. She might just run away. Who knows? So we want to set her up perfectly to give her the best possible longevity of her device and best possible clinical outcomes, okay? So we'll start with basic operation over the left-hand side. And the default, so do we want, I'm going to go, what mode do you want?
For what?
What mode? What pacing mode? So, is everyone happy with DDD? Yeah?
I would be happy if she has a
normal sinus node. So we want to turn the sensor off, yeah?
Yeah.
Absolutely. I was in South Africa like last year, and they put rate response on everybody.
No.
This is crazy. If you have a normal sinus node, leave it alone.
Yeah.
Just leave it alone. Because it's much more physical. Leave it alone. But yeah, they program it on everybody.
Patients, we should not.
Absolutely. And for patients with ischemia who, rate response can push rates up, which can cause angina. Absolutely.
I want to ask about this because I have no. What is passive compared to off?
So passive, the device will give you diagnostics about what the sensor said the heart rate should be. Okay, so if I just quickly come into that and then go, and I'll just show you what it looks like. So under the diagnostics, then I'll just do the programming. So under diagnostics, if we have the sensor on passive, you see these yellow balls here. These yellow balls tell you what the sensor thought the heart rate should be. Okay, so these yellow balls here tell you what the sensor. I always would put it on passive. It doesn't cost any energy, no energy cost, but it gives you some potentially useful information should the patient start to develop SA block or SA nodal disease. And also in your CRTs, it's really useful as well, because the sensor will tell you what it thinks the heart rate should be most of the time, and if your atrial rate is far to the right, then that probably means they're not taking a beta blockers, right? So if the device is saying this here, 80–90% of the time, they should be between 60 and 70, which is probably what most heart failure patients should be, if they're beta blocked properly. But the heart rate curve is over to the right. There's a mismatch. Over here, faster heart rate. Yeah. So let's say on her atrial rate is going at 85, but her sensor is saying she should be at 70. You've probably got sympathetic nervous stimulation from heart failure. So probably they're not taking the beta blockers. Yeah. So we're going to only use a sensor, absolutely only use a sensor if the patient has got something wrong with her SA node, okay? Leave it alone, right? How do you know if someone's got a problem with their SA node? Well, it's difficult, but they might be in quite profound sinus bradycardia. You might send them for a walk and the heart rate doesn't go up. But also you can look at 1 month or 3 months or 1 year in the diagnostics. So you go into the diagnostics, and if they are sort of 90% of the time in the lower heart rate bracket, okay? So let's say we program it from 60 beats per minute to whatever. If they are 90–95% of the time in that lower bracket, they may well have, in the lower heart rate bracket, they may well have sinus node disease, and you might want to consider that, because rate response can help, okay? Rate response, they can walk, the accelerometer picks up, the heart rate goes up, okay? So we're not giving this lady any rate response, okay? So no rate response, just passive, collect information. Over here we've got triggering, we can all this. Battery magnet response is the battery test, so we put the magnet on and it tells us how good the battery is. And noise aversion mode, typically would leave this at DOO. So noise aversion mode means that if they come into an environment where there is lots of high frequency noise, and usually that means it's mains electricity. So something in a house that's kind of, they're touching, that they're getting electrical current running through them, which they don't feel, then the device could inhibit, okay? So it's very, very fast. So for instance, if my electrical system in my house is not very good, and I'm touching the taps, and current is going in my arm, and coming up here and coming out this arm, that could inhibit the pacemaker, okay? You're not going to be electrocuted, it's very low current. Okay, but it could inhibit the pacemaker. Noise aversion mode says if I detect very fast, very, very non-physiological, I'm going to pace asynchronously during that noise, okay? So in patients who have AV block and stuff, this is a good idea to leave this at the nominal, which is DOO, okay? So that's step one. Step two, the rates. So what rate do you want to pace this lady at? Remember, she's 65, she has no SA node disease, but she has intermittent AV block. What heart rate?
60.
60. 60?
Yeah. Sometimes hysteresis can help.
Yeah, sometimes hysteresis can help, okay? Do you want to pace this lady at 60 beats per minute in her atrium at night? She has no SA nodal disease.
Do you have night
have a rest
Do you have
rate?
night
We have rest rate, yeah. So we have rest rate. So what rest rate does, this is nice, right? So we put this on
40.
40 maybe. I would do 40, absolutely. So this means that when she sits down in her chair or goes to bed at night, the accelerometer in the device, the thing that gives rate response, says we're not moving. The human is not moving. So make the heart rate go lower, because when the human doesn't move, the human doesn't need fast rates, okay? So it decreases the base rate to 40 beats per minute. Because for sure, this 65-year-old lady will go less than 60 beats per minute at night, right? When she goes to sleep, it's not. Heart rate will go down probably to 50, okay? If we don't do this, we're going to pace her in her atrium at 60 beats per minute, probably 1/3 of her life, because they're asleep for maybe 8 hours, right? So you're going to pace them when you don't need to for 30% of the time. That's a waste of battery, right? Don't do that. They don't need it, and it might not let them sleep very well. So rest rate is really helpful. It will save your battery a little bit, and it will stop delivering inappropriate atrial pacing. Pacing that is not required, okay? So this is a good idea. Rest rate on. Also a good idea is hysteresis. So hysteresis, when there is intrinsic conduction, or when it's not intrinsic, when there is, in a dual chamber device, when there are spontaneous P waves, it lets the heart rate drop. It has a lower band, okay? So it's a different type, it's a new base rate. So we'll maybe put that in at 50, okay? So this means that, and then I'll just put a search interval on. Because can you imagine a patient at 60, you never see a P wave, so you never drop your hysteresis to 50. So we should search. So if they're patient at 60, pace, 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 every 1 minute it will drop the rate to 50, and if there's P waves, the base rate is now 50, okay? If then we hit 50 and pace at 50 beats per minute for one cycle, I can make this 3 if I want. 1, 2, 3 at 50, goes back to 60, okay? Yeah?
What is the accepted difference rate between base rate and hysteresis rate? 10, 5?
Depends on the patient. Depends on the patient. 10 is reasonable. 20 maybe? Depends on the patient. Yeah, you could even do up to 20. Yeah, it depends on the patient. On a patient like this who had good SA node activity, I would maybe even do 20. And some people would just put this at 40, right? You could do, or even 30, right? Because if you have normal SA node, well, it's normal, it's not diseased, so leave it alone. We're just tracking it, right? All we're doing is tracking it, right? So there's an argument for just not being complicated.
If you're so sure that
If you're certain, yeah, this is the point, yeah. But these patients, if she has AV block, she will get other blocks, right? So this is a safer, more conservative scheme, okay? But if you're sure, so let's say it was a 33-year-old patient who had I don't know, do you do TAVIs? Do you do many TAVIs? Like sometimes, yeah. So let's say you do a valve and you cut through the AV node accidentally. A surgeon does a an aortic valve replacement, cuts the AV node in a young patient who's got rheumatic heart disease, you know what? They've got a normal SA node. So you'd probably be quite comfortable leaving them at 30, right? DGD at 30, right? And then never placed their atrium. But there's no problem with the atrium. The problem's with the conduction through the AV node, yeah? Yeah. So we can decide that on the individual. Okay. So this is optimized. I think this will help her. Will reduce atrial pacing burden. Max sensor rate is irrelevant because we don't use the sensor. But the max tracking rate. What are we going to put the max track rate to? So she's 65. She has no coronary artery disease. Zero coronary artery disease.
Maximum target rate. We measure her maximum target rate.
Yeah. So 65, 220 or 200 minus 65 would be reasonable. So sort of 140-ish, 130, 140, 145 beats per minute. Because when she exercises, she may get back to good, you know, she you know what, she might run, right? She might do, I don't know, she might go to the gym, she might exercise. If we don't put this max track rate above her max sinus rate, she will get wanky back. She will get pacemaker wanky back, okay? And they will get symptomatic of that, okay?
Yes,
Very, very symptomatic. I mean,
test.
no, I wouldn't. I would just look at their sinus node and put this more. So I would, and this lady.
How could you look at the sinus from the passive sensor? From the sensor?
Yeah. Well, yeah, we can get an idea of from the diagnostics. We can tell what heart rate she's achieved. So, but for her, I'd go 220 minus 65. So you know, whatever, 150-ish. So let it track up to about 150. I mean, think about most 65-year-olds. They don't get the heart rates much above this number here, right? In normal sinus rhythm. Okay. If you don't do this, if you don't give them this, they can be walking and then getting short of breath because they have a delayed, their AV node gets delayed, right? So they sense the P wave and the device delays the ventricular pacing pulse until it's 130, okay? And I've seen pacemaker patients who have had this number wrong and they are extraordinarily symptomatic on exercise. So they're exercising, everything's good, and then they go, oh my God, I feel really bad, and they're dizzy and they're falling over and hanging on to things. So then they go, I'm not exercising again. And then they get fatter and they get less fit and and all this kind of stuff that happens, okay? I had one 8 weeks ago in a hospital in Yorkshire, in the top part of England, and she was 35 years old, right? So she's 35 years old, had a pacemaker put in what she had to put in for? She had to put in for intermittent AV block, but there was quite a lot of AV block was going on, and her max track was left at 120 for 5 years. Okay, so 5 years she's had a max track at 120 because that's what the box came at from the factory. So they just left it at 120. And this lady had been coming back to the cardiologist and saying, I can't exercise. So she was a slim 35-year-old. I can't exercise. When I exercise, I get really short of breath and I have to stop. So the cardiologist examined her, said, well, I can't see anything, nothing obvious. She kept coming back, and everybody in the hospital said, you know, in cardiology said, oh, this patient is really difficult. She's really difficult. Because she kept coming back complaining she couldn't exercise. The cardiologist then said to her, well, I mean, it might be something to do with your lungs. So we'll send you for some lung tests. And so the lady's now worried that she's got a lung problem as well as a cardiac problem. She had no problem with her lungs at all. All it was her max track was at 120. Okay? So they asked me to come and see if I could help her out. And it was pretty straightforward. I put this to 190. She has no other complications. 190 beats per minute. And we put her on a treadmill, and she did the Bruce protocol. She did 15 minutes on Bruce protocol. She was running on the treadmill, and she was like looking at us. She kept looking at us and saying, like, "What have you done?" I think she thought I was some kind of, you know, being from outer space. But actually, it's really straightforward. Really straightforward. Okay, but that happens. It's not massively. It's not uncommon. Okay, so they just made it really bad. So. This is an important number. It can cause really significant symptoms.
So it's logic to increase the maximum track rate for the young people that not documented of any arrhythmias, any atrial arrhythmias after implantation to increase the maximum track rate to about 180 or 190 from the start?
I would, absolutely, 100%. Absolutely.
Depending on the target heart rate.
Yeah, depending on the target heart rate of the patient. So if you've got a patient who's got ischemic heart disease, triple vessel disease or whatever, you limit that. You want to be limiting that to probably not much more than 115, 120 beats per minute maximum. That's it. Otherwise, these patients, those patients are being heavily beta blocked anyway, usually. So, they don't typically reach those numbers very much. They're not very active patients. But you're young, fit, no coronary artery disease. They don't even have to be young. I mean, I've seen patients at like 55 years old who are extraordinarily fit, really fit. They develop AV block for whatever reason, and you need to have them up at 170, 180.
Yeah.
And sometimes people go, oh my God, you can't go 180. Why not?
Yeah.
If they didn't have AV block, they would go at 180.
Yeah.
So just let it be physiological. Yeah, it's potentially a big problem. Okay, so we've kind of done most of that screen. Next one we'll go to our AV delays. Okay, so remember she has intermittent AV block. So maybe 10% of the time or less, 2% of the time, maybe even 1% of the time, this lady goes into AV block and falls over.
Excuse me.
Yes.
The previous page.
Sorry.
The previous one. Yeah, the intervention rate on the right.
This is to do with if you put pacemakers in for people with vasovagal syncope.
Yeah.
So you would activate this for do you use pacemakers for vasovagal syncope?
Not anymore.
Not anymore. Yeah, I think the evidence for it is nearly gone away. Yeah, going down. Yeah, but this, if you did want to pace someone for vasovagal syncope, you would introduce this algorithm. I've got a case study. We'll talk about it later on. Okay, so show you how if you did put one in. But yeah, I think lots of people are not pacing for vasovagal syncope. It's about salt levels. It's about avoidance techniques, things like this here. So sometimes when I hear about people having pacemakers put in for vasovagal syncope type stuff, I think, yeah, it's not good. Not good. We had a case in London of a marathon runner lady. So she was a marathon runner, and she'd run a half marathon. She got back to the hotel. She ran a hot bath. She got in the hot bath, sat in the hot bath for 20 minutes, and then passed out in the hot bath. So her husband was there. She was drowning in the bath. He dragged her out of the bath, and they put a pacemaker in her. They put a pacemaker. It's like. So actually what should have happened is she shouldn't go in hot baths after she just done a half marathon, right? Because then and she was the typical kind of vasovagal patient, blonde, very kind of double jointed almost, very like loose connective tissue. So she got a dual chamber pacemaker put in, and she's 27. She doesn't need a pacemaker. She doesn't need a pacemaker. Just don't get in hot baths.
Do good for her.
Yeah.
She will not do marathons anymore.
No, she can do marathons, no problem. Just don't get in a hot bath afterwards. That's it. No. So it's avoidance. Avoidance is salt, and then usually it's fixed, right? Usually, not always, but sometimes you might do. But I've got a nice case study. Okay, so the recap: AV block, a very intermittent AV block. Okay, normally she's in sinus rhythm with a reasonably normal PR interval. Okay, what are we going to do with her AV delays? So remembering what an AV delay is for some people, the AV delay is the amount of time the device waits until after it sees a P wave to when it paces the ventricle.
Increase.
You want to increase it?
Yes.
Why do you want to increase it?
Decrease the pacing.
To decrease the pacing? Why do you want to decrease the pacing? Lots of questions. Because she doesn't need it.
When she doesn't need it.
Yeah, well, if you don't need it, don't do it, right? That's a good, right? So if you don't need it, don't do it, right? And also, RV pacing could be, if we pace a lot, it can be bad for certain people. Not all people, but some people, especially if you've got slightly depressed left ventricular ejection fraction, if you RV pace, that comes a negative outcome. And even people with normal ejection fractions, you can cause problems, okay? So if we don't have to pace the right ventricle, we shouldn't pace the right ventricle because it saves the battery, but more importantly, it prevents the patient from getting potential heart failure symptoms, okay? And AF, right? So there's lots of RV pacing makes AF more common as well. So it makes AF more common, makes heart failure more common, induces left bundle, and it uses your battery. So let's not do that. So we can either make these fixed and long, okay? So we can program the sensed AV delay. Mostly this lady will be sensing her P-wave, So this is the one that's really important. Or we can use this algorithm here. This is ventricular intrinsic preference. So that means it's promoting intrinsic conduction, okay? And here's the numbers here. So the VIP extension, this is the extension on the AV delay of 200 milliseconds above this, okay? So if we have conduction through the AV node, the operational AV delay will be 350 milliseconds, okay? If I click this panel, I can then make this a little bit more aggressive if I want. I can press this 200, and not in this situation, but in other situations I can make that longer or shorter. And I can also search more frequently. I can search for intrinsic conduction maybe every 30 seconds. So if we're pacing in a ventricle, every 30 seconds it will make the AV delay longer by 200 milliseconds on top of our AV delays, okay?
So shortening the searching interval will
lengthen the AV delay.
Will delay will delay the pacing.
It will delay the pacing by 200 milliseconds every 30 seconds for one interval. And if we want to be reasonably aggressive, which in this lady I would be, right?
Yeah.
So every 30 seconds it will go long for 3 cycles. So it'll go ascends, long, ascends, long, ascends, long. And if all 3 of these are long, if one of these is long, then it will stay out long, okay? And it will promote intrinsic conduction.
Okay. So this is 1 out of 3.
1 out of 3, yeah.
If it is long, it stays long.
Yeah. Sorry, no, it's not. It's not 1 out of 3. In this one here, 3 out of 3 will have to be long. Sorry, this is 3 out of 3. But outside of the search, so maybe at 15 seconds, we see an R wave. So we see intrinsic conduction, then it will just go long. Okay? So 1 beat outside of a search, 3 beats in a search. Okay?
What is the difference between increasing the VIP extension and increasing the original sensed AV delay? What's the difference?
Yeah, good question. So the question is, what is the difference between making this longer or, well, so I've got a maximum of 350 here, right? So why don't I just do this?
Yeah.
Why not?
Well,
Well, I can get 325, right? So 325. Why not just do this? You can do this, right? Let's push this up higher. I can't go any higher. So we're at 325. Let's turn that off for a second. So I could just go very long AV delays, right? The slight issue with this is when she gets AV block, we would then be A-sense, V-pace at 325 milliseconds. That's pacemaker syndrome, right?
And it will also affect the maximum tracking rate.
And it will affect the max tracking rate, absolutely. The max track will be drawn down. You can see the 2-to-1 block rate is now 134. He's clever, right? Did you train him?
He's my student.
Your student, yeah.
And he's not polluted.
So, yeah, absolutely. If you go very long AV delays, a fixed long AV delay, you've got very long first-degree AV block, right? Which can induce heart failure symptoms, okay? So in this situation, if we did that, when we paced, we would have a ton of mitral regurg. We'd have mitral regurgitation, tricuspid regurgitation, patient might not feel great, okay? So the idea of VIP is when they pace, they get more physiological AV delays, okay? When they have intrinsic, we let it go, okay? Okay?
What I know clinically, if you have a patient with intermittent complete heart block, it's not recommended to keep the VIP on. Is it right?
For intermittent, for intermittent AV block, I would use it. Yeah, no, absolutely, absolutely, 100%. That's
keep it on.
Yeah, absolutely. I would keep VIP on in a patient with intermittent AV block. If they go permanent, turn it off.
Of course.
Go permanent, turn it off. But the intermittent AV block, I would have this on. Absolutely.
Okay.
Yeah, 100%. That's primarily what it's designed for.
So what is the optimum AV sensed AV delay?
Who knows? Probably, so the HRS gives a little bit of guidance on this a couple of years ago, and it's probably, if you go over 280 milliseconds, 280-ish, 300, then it starts to, the curve turns this way here, okay? So then you're probably better doing short, physiological AV delays.
But I noticed that all companies give 150, 180.
Yeah.
Based on research? Or
So the 150, 200 nominal is based on an average of kind of PR intervals, right? So will I accept these numbers? Probably. No, I wouldn't. And I'll just program this in, and I'll show you an algorithm. We have an algorithm that can potentially give you close to the best possible AV PR interval or AV delay. So if I go to the front screen here, there's an algorithm down the bottom here. It's quite hard to see, called QuickOpt. So QuickOpt measures the P-wave duration. Okay, so you can move. So and this is on dual chamber devices as well, right? So if you know how long your P-wave is, then you probably know what a physiological AV delay should be, right? Because if your P-wave is 100, you probably don't want to be pacing much before 100, right? Or if your PR interval, your P-wave is, say, 140, and you pace at 150, that's too short.
PR interval.
Yeah. So no, the actual P-wave. So measure
P-wave duration.
P-wave duration, yeah. So we measure how wide the P-wave is automatically.
How come this is intracardiac?
Yeah, it's clever. It goes unipolar. It goes into unipolar mode and measures from the tip to the can, and we can see left atrial activity.
Oh,
That's clever, right?
that's very good.
That's clever, right? So then you can measure intracardiac your P-wave duration. So if you know your P-wave, if you do that, right, you know, we all know, right? The P-wave ends, and then a little flat bit, and then the R-wave happens, right? Right? Because that's physiological. That's genetically physiological, right? So if we know the P-wave from the device, we know that we shouldn't pace shorter than the P-wave. Yeah, we should. So if the P-wave is 140, it's unusual. If it's 140 and we pace at